We'll try to get started and get through this. We're going to talk today some protocol revisions to the to our standing orders and also a couple of new concepts that are in the protocols as well. This probably won't be the only protocol revision in the next 12 months, but we'll sort of work things in slowly. Some of the things we're going to talk about today won't come into effect for about a month. It takes a while to get these done. I'm going to have to peer around a little bit. I had a cataract done a couple of weeks ago, and I still haven't quite adjusted to the changes. Yes, it was only on the left eye. It was pretty interesting. I showed up to have it done, and the nurses come in, the anesthesiologists come in, they do all the stuff, and they said, "Oh, we're going to put a big green dot above the eye we're going to work on." I said, "Well, that's fine. I know you have to do that. That's protocol. But you know, if I wake up and I find that you're operating on the right eye, we're out of here." No, that's a different thing. So. Okay, first thing to talk about, a new concept, and I'm sure that'll throw a couple wrenches into the way you do things now, and you're concerned about it. But this is the pediatric thing, and it's a new, you know, pediatricians deal with small things, so they have to come up with a couple of new ideas and new rules. But this is a very important one. It turns out, when you look at the statistics, that it's highly predictive of serious problems. And it's called an ALTE, or apparent life-threatening event. And the definition is an episode that is frightening to the observer. The observer is the parent, or or a babysitter, or the grandparent, which is even more likely. And but it's an item that's very frightening to the observer that the child exhibits. And it's either, they could have a combination of apnea, color change, cyanosis, marked change, cyanosis, or become all of a sudden extremely pale, marked change in muscle tone, choking, gagging. You know, all babies spit up, all babies gag a little bit when they're feeding, or most do, but it's not frightening. The mom says, "Hey, well, the kid choked a little bit," you know. So the parent got really anxious. This may account for up to 7.5% to 8% of all pediatric EMS calls in the infant age group 1 to 12 months. But it can occur in any age up to about 3 years of age. So we're calling an ALTE, that could be a frightening event that occur up to age 3. It's not well established, but you can have up to about, they think is about 3 per 1,000 births, or so that's 0.3%. Mean age is 3 months, 55% being males. You know, those of you who are thinking ahead on this may say, you know, some of these ALTE events may be preceding what turns out to be SIDS. And that's the reason we talk about this. It's a group of symptoms, not a disease. There's no disease, there's no virus involved, there's no ALTE virus. That'd be a great thing to invent, you know, you could treat it then. As many as 10% of the patients require emergency department or hospital intervention. So they're either intubated in the emergency department or some major intervention occurs. They do all require a workup, in our opinion. So all patients who have what we're going to call an ALTE, it should be transported. Now, your job, our job, is to determine the severity, the duration, and the kind of nature of the event. If the parent and guardian doesn't want to transport, says, "Oh, well, the child is fine now." That's the problem with ALTE. You show up, There's no problem if you get there and the kid is seizing, cyanotic, apneic. That's not a problem. What happens is you show up with an ALTE, and by that time the child looks okay. And the parent says, oh, I don't know why I called you. So if the parent, guardian doesn't want to transport the child or is refusing medical care, that's an automatic and mandatory medical control contact. Put them on the phone with the doctor. Now, etiology. What's the etiology of apparent life-threatening events? Well, they could be reflux, but they could have underlying cardiac abnormalities, two non-accidental traumas, a certain percent. It's a low percent, but a certain percent of these turn out to be shaken babies. Hospital workup for an ALTE requires a battery of tests, and often gets a septic workup and a cardiac workup and a respiratory workup simultaneously. And often, you don't find a definitive cause, but you become anxious about it. Up to 50% of cases will have a defined cause. 50% are gastrointestinal, and it could be anything from gastroesophageal reflux, which does occur in babies, where the cardium, the sphincter at the diaphragm, will become patulous, very doesn't squeeze, and the child just refluxes. Could be from abnormalities, congenital abnormalities of the intestine. Could be from congenital abnormalities of the stomach. They can get hypertrophic pyloric stenosis, which babies start vomiting, and then they aspirate when they vomit. 30% can be neurologic or neurogenic in order. So there could be a problem, underlying seizure disorder in the child. 30% of childhood seizures are evident by the time the child is 3 months old. 20% could be respiratory, viruses, pre-aspiration pneumonia, all sorts of things. 5% cardiovascular, metabolic and endocrine count for a small percent, and then non-accidental trauma. Drugs and toxins are very low on the list. They can occur, but it's uncommon that a child under 6 months of age would be into drugs or toxins. If they start crawling early, I suppose. So we're talking about the ALTEs that occur in older age group kid that might have gotten into grandpa's pill. Beta blockers. So in your assessment, in anyone's assessment, the circumstances associated with the symptoms, history of color change, irregular breathing, change in muscular tone, those are the key things to clue on. Ask if they have concurrent symptoms, fever, cough, rhinorrhea. Have they had a cold recently? Have they had anything going on? Any diarrhea, vomiting, rash, labored breathing? If they have a prior ALTE, if mom says, a week ago he had an episode just like this is a big red flag. If they had one within the last 24 hours, it's a big, big red flag. There's a family history of SIDS, also a red flag. If one kid went down with SIDS, another one can too. Ask what treatments, what interventions, how did the kid start breathing again? Did the mom do mouth to mouth? Did they shake the child? What did they do to get the child going again? Was there actually CPR done? Compressions. Premature birth before 37 weeks of gestation is another red flag. Past medical history for an older child, history of seizures, previous seizures, history of injury in childhood, and a history of reflux disease. Exam, kid gets a full set of vitals, even if they're looking okay. Look for signs of respiratory distress. Obviously, grunting, nasal flaring, retracting. That kid is sick at that point. It's not looking okay. You may need to intervene. You do need to intervene at that point. Color, are they pallid? Is there cyanosis? Are they normal? What's the mental status of the child? Obviously, an infant is difficult, but they would be, are they unresponsive? Do they respond to the mom? Are they consolable by the mom? Are they seeming normal? Are they flaccid, tired? Obviously, looking for physical signs of external trauma, ruling out the child abuse cases. Kids should be put on a cardiac monitor, get a pulse oximetry, get a finger stick or heel stick blood glucose. Supplemental oxygen if there are signs of respiratory distress. Now, escalate. We don't want these normal children or children who respond to routine and a routine stepwise approach to the airway. We don't want to go right to intubation. So escalate from a nasal cannula, face mask, non-rebreather, and more advanced airway as needed. Obviously, that kind of a child, when you need to think, gosh, I might have to intubate this baby, you're not thinking you're going to leave this baby at home. And the parent is not thinking that either. These aren't the ones who are going to argue with you. If they have excessive secretions, use a nasal secretions, use a simple bulb suction or a suction catheter if you have to. Place an IV if you have clinical concerns of shock, or if you have to give medication. If the child's having a seizure, obviously you probably need to get a line in there, although you can give Versed IM. I prefer it, and you prefer it to give it IV. More works faster, better control. But a normal appearing child, just because you're going to transport them to the hospital, you don't have to start an IV on that kid. If apnea persists, obviously approach your advanced airway the way you always would do. Bag valve mask first, supraglottic devices and/or intubation. We don't carry many supraglottic devices for little kids in this county. If you need to if you need to intubate the child, you intubate the child. But only do that if your bag mask is failing, or if they're apneic and respiratory failure. Least invasive method possible. That's always true with the kids. So, regardless of the child's appearance, you've had an ALTE, you've evaluated it seemed to be a real thing to the parent, to the guardian. All patients with a history of sign or symptoms of ALTE should be transported for further evaluation. Obviously, and we don't even consider, transport any patients with history of cyanosis, significant past medical history, even if they look good. Any past history of an ALTE, a resuscitation attempt by the caregiver, or more than one ALTE in that 24-hour period. Those are absolute, no question at all. And you should go to any ED facility in Clark County has the ability to evaluate and manage these children. Now, no facility, if this child needs to be admitted, particularly to a PEDS ICU, no facility in Vancouver, in Clark County, will admit that child, because the only pediatric intensive care units are in Portland. But we're not going to transport all these children to Portland when they can have when most of them the vast majority will have a workup in the ED and be released home. If they need to be stabilized, we stabilize, just like you do with trauma. If we have a critical PEDS trauma, we will stabilize them in Clark County and transport them as needed. So what's the prognosis of an ALTE? Morbidity, significant illness, and mortality, significant illness, vary according to underlying diagnosis. But the range is 0 for non-significant ALTEs to up to 6% for the ones that are caused by significant problems that we may or may not miss. The recurrence rate of ALTE is 0 to 24%. So about a quarter of the kids you see will either have another event after they are evaluated for the first event, or they will have had, their parent will have said, geez, they had something just like this 2 days ago, and they've been fine ever since. Long-term outcomes for those that have unexplained ALTE are unpredictable. But ALTEs that have severe events requiring resuscitation, or an event that's recurring, or a diagnosis of a seizure disorder, ultimately, they hold up to about a 25% risk of death. So some of those will turn out to be, it was a SIDS case. Some of them will turn out to be a seizure that will ultimately end up in a respiratory arrest. So your protocol, which has been added, it's F3 in the PEDS protocol, apparent life-threatening event. An ALTE is defined as an episode in an infant which is frightening to the observer, includes one or more of the following: apnea, color change, marked change in muscle tone, gagging, choking. Support ABCs, follow airway management and respiratory distress protocols, place patient on cardiac monitor, consider obtaining blood glucose. Don't consider it, do it. Obtain, that's what we mean by consider. Obtain a detailed description of the event, duration, nature, severity. All patients should be transported to a hospital for further evaluation. Online medical control is mandatory for any patient with suspected ALTE where a parent or guardian wishes to refuse. Now, you may well say to me, Dr. Whitwer, I took this kid in, he looked perfectly fine, I dropped him off at the emergency department, and the ER doc said, you dumb shit, why are you bringing this patient in? This kid looks perfectly normal. Well, Dr. Bell and a physician at Legacy Salmon Creek will take care of educating, and this is being simultaneously educated to you and to the ED docs. The ED docs have seen this before. This has been in the literature. And yes, some of us read, so you will see it. But we will be educating them that they will be coming in, so they will not give you grief. Well, I apologize if they do, because we won't get to everyone, just like I don't get to every medic in the county every minute either. But we will re-educate them after the fact if that's the case. Just smile and say, this is in my protocol. You can show them the protocol if you want. We will educate them. We will take care of that. The most important part of that equation is that when you have a patient, a guardian refusing transport, you need to be on, the ED doc needs to be on the same page that you are when they're talking to the family. So we will take care of our end of that, doing that education. Now, remember, this is a group of symptoms, not a disease, generally seen in infants under 1 year of age. It can occur up to, it says 2, an earlier slide said 3, let's say 2 to 3 years. It's uncommon beyond a year. Most patients have a normal exam by you, but underlying causes can include pneumonia, bronchiolitis, seizure, sepsis, intracranial hemorrhage, and meningitis. Kind of things we want to rule out. Up to 10% of these patients will require intervention in the hospital, either in the ED or in the pediatric unit. Okay. Any questions up to that point? Is it clear, crystal clear, as they say? Okay. Now, we will, you guys are getting it will be in the protocol. Hopefully tomorrow you won't have a case that you have to call the ED for. Might happen, but this protocol could be in effect at this time. We have had ALTE cases, and we have one in case review, so we'll get to that. So they do occur. So this is to give you, I guess the point is if the parent or guardian is worried for something, this usually means that something did happen. So now on to restraint of patients. Talk a little bit about Haldol, haloperidol. And the reason we're talking about this is because although my favorite drug is an napsine, you can't get an napsine right now. There's no point, and there's no point in worrying about it if you can't get it. I mean, it's a drug thing. It's a drug supply thing, and nobody can get it apparently. Haldol is a good substitute. Haldol is one of the sedative drugs that has been used for a long, long, long time. As a matter of fact, it's the favorite drug of the emergency department in Denver, at Denver General, where they get all the really aggressive. And the rule with Haldol, starting about in 1970, when Haldol first came out, was that if the patient was aggressive, if the patient was hitting the nurses, cursing the nurses, spitting at the nurses, doing anything that the nurse didn't like, they got 5 milligrams of Haldol IM. If he continued, you did 5 milligrams until they were nice. And the average at that point was getting about 30 milligrams of Haldol, where at most people, even rather large aggressive folk on amphetamines, in those days it was just straight amphetamines, meth hadn't been invented, they would they would sit up in bed to yell or to hit at you, and then they'd pass out because they had orthostatic hypotension from that much Haldol. That keeps people down at least. Haldol is a butyrophenone derivative. It has antipsychotic properties, and it's particularly effective in managing hyperactivity, agitation, and mania. Obviously, was developed first to take care of schizophrenics who were manic, or any manic person. It does have antiemetic properties, although we don't recommend it to control nausea. We have other things to control nausea. It has, however, a tendency to provoke extrapyramidal effects. It has weak, although present, alpha-adrenergic properties, which causes the hypotension. Alpha-adrenolytic properties. It knocks out your alpha. So enough Haldol will make any of us hypotensive. It also has, like all drugs in the butyrophenone category, like almost all, like napsine, any of the antipsychotic drugs have QT prolongation properties. If you prolong your QT, you have the chance of going to a torsades. That's the worst endpoint. Now, The safety factor on that is that unless you have a tendency toward QT prolongation, in other words, congenital prolonged QT syndrome, or you're on other medications or other conditions that already prolong your QT, there's really no worry on the dosing that we give. But because you have the potential for QT prolongation and the potential for torsades is why whenever you use any of these drugs, you have the patient on a monitor. You have the patient on a monitor so that you don't have to say, oh, I was just watching him, all of a sudden he twitched and had a little seizure and I didn't know what was going on. And then when we finally hooked him up to the monitor, he was in a torsades. I want you to know that he goes into the torsades quickly, you know. And also, if you're really, really, really good and you study, and Mike Hollingsworth teaches you how to read QT prolongation in a tachycardia, then you can predict it. So, precautions with Haldol, same, use it in reduced doses if there's renal or hepatic impairment. The elderly all have a little bit of remember, those are older than 72. They have a little bit of a decreased renal function anyway. They have decreased liver function anyway. Hypotension can occur if you give it. That's not a bad problem if you got the patient laying down on a gurney anyway. You can have QT prolongation and torsades in the susceptible patients. CNS depressants they are potentiated, so narcotics, if you give it along with a narcotic such as morphine well, you don't have morphine, so give it with fentanyl that will potentiate the fentanyl. If you give it with Versed, it potentiates it, which we're going to use for our advantage in a minute. And you can get extrapyramidal symptoms. The worst things are dystonia and tremors, dystonia, inability to walk. They can have the severe case is oculogyrate crisis. Their eyes seem to get stuck to the side. They're not having a seizure. They're awake. Their neck twitches. They feel terrible. They know they're going to die. Akathisia is the most common thing. It may be due to, in my experience, it's due to not giving quite enough of the Haldol or anapsine. Anapsine is very common to get akathisia. Akathisia is that I just don't feel good, creepy, crawly, icky feeling that they will describe. And that's a little harder to cure actually than it's really great to get the guys with the oculogyrate crisis because you give them a little Benadryl and all of a sudden they get well and they think you're God. Akathisia doesn't always go away that quickly. Sometimes you have to kiss them with a little Versed along with the Benadryl. Now, why do we use Haldol or anything like it? Okay, sedation to facilitate restraint of combative patients in emergency situations. Contraindications, people who are allergic or have a known idiosyncratic reaction. So if somebody, or an EPS kind of reaction. So if the patient says, now, if the patient's sitting there calmly enough to tell you that, oh, I don't really want to take anapsine or I don't want to take the Haldol, odds are in this community they probably haven't had Haldol in emergency situations. We've used anapsine for years, so they're probably relatively virginal to Haldol. But if they tell you they're allergic, ask them what they mean by allergic. And they say, oh, I felt all creepy crawly. Well, it's probably not a good idea to give it to them then if they have the creepy crawlies. They'll probably get it again and they'll be mad at you. If they have known congenital QT prolongation, If they have Parkinson's disease, well, they've already messed up their extrapyramidal systems, already messed up. Why mess them up more? Severe metabolic derangement, hypokalemia, hypomagnesemia always contributes to prolonging your QT. So when you go into the place and you have an agitated, skinny person vomiting in the corner, and they're still agitated and hitting at you, and there's Karen Carpenter music playing in the background, don't give them Haldol, okay? Don't give Haldol if you don't have any Benadryl, and we do run out of Benadryl sometimes. Have to look in your box, drug box. And if you don't have them on a monitor, or you can't put them on a monitor, don't give them. You don't have to put the monitor on immediately, that moment, but shortly thereafter. So we'd like to give it IV if possible. IV established. Give Haldol 2 to 5 milligrams IV, or 5 milligrams IM, higher dose IM. It takes longer to get in. It takes longer to take effect. You can repeat every 15 minutes to a total of 10 milligram max dose, either way. Children get a dose of 0.1 milligram per kilo, but not to exceed the adult dose. Now, we're going to talk separately about excited delirium, but in excited delirium, you can give Haldol 10 milligrams along with Versed 10 milligrams IM. You can also use Geodon instead of the Haldol, but we'll talk about that. If you have with Haldol, if you have extrapyramidal symptoms, dystonia, akathisia, oculogyric crisis, Benadryl, 12.5 to 25 milligrams. I'd take 25, thank you. Children, 1 milligram per kilo IV or IM. Patient must be monitored on a EKG. Record and monitor vitals and EKG after administration every 5 minutes, looking for hypotension. If hypotension occurs, simple fluid challenge. If you got excessive Haldol and excessive hypotension, because it's an alpha adrenolitics drug, you give it an alpha drug would be nice. Give them back a little epi drip. If QT prolongation or wide complex, treat by protocol. What do you treat wide complex tachycardia or torsades with? MAG. So now, we restrain patients because the patient's a danger to self or responders, you. Sedative agents are needed to restrain violent patients, but you need to evaluate them. How many people do you need to take down a combative patient? Safely 4, but 5 is an ideal number because it's always good to have somebody on the head. So treat the medical causes of combativeness. So if the patient's hypoxic, treat that. If they have head injury, we don't want to necessarily give them sometimes we have to restrain them chemically. Treat hypoglycemia. That's an obvious thing. We don't want to give somebody max dose of Versed and Haldol if they're hypoglycemic. That looks very bad on the record. And then think about excited delirium, which is sort of beyond the pale of agitation and violence. So your procedure, once again, is actually more straightforward than it appears as we read it. If the patient, you have to evaluate why you think this patient is agitated and needs to be chemically restrained. So you've gone through the process, you Say he's agitated because he's psychiatric. He's an agitated schizophrenic in a manic phase. He's stopped his drugs, whatever. And if it's psychotic, we treat it with Haldol. So you give Haldol, IV or IM, repeating up to the max dose of 10. And the alternative of that is Geodon, 10 milligrams IM only. It can only be given IM. That's what makes Geodon a nice drug for really agitated delirium. It can only be given IM, and you can often get only you can't get an IV started in these guys. Now, if they have EPS, Benadryl 12.5 to 25, and if they had the akathisia and you needed to give them, if they're still agitated after 10 minutes, give them a little kiss of Versed. Now, if, however, you think, hey, this guy is just a meth head. This guy is on coke. This guy is on a combination of everything. And this is drug-induced agitation. Then start out with Versed and 2.5 to 5 milligrams IM or IV. Obviously, a higher dose IM. And you can increase that, then you can repeat up to a maximum of 10. At that point, if you've done the max dose, let's say you thought this guy was just simply psychiatric, you've done your max dose of Haldol. What's the max dose of Haldol? 10. And he's still wacky and trying to take you out or trying to harm himself. Switch now and give him the other category of drug. Give him some Versed, and you can give him up to the max dose of Versed. But you do the max dose of psychiatric drug first, and then switch to the sedative, true sedative. Now, if it's the other way around, same difference. If you had given him you thought, oh, he's a drug overdose, he's a meth head, I gave him my full 10 milligrams of Versed, and he's still uncontrollable, then give him some of the Haldol or Geodon, which is depending on what you're carrying. Hopefully you're carrying only one and not both. Because you don't give them Haldol and Geodon together. Use one butyraphenone derivative, one psychiatric drug, and one sedative drug only. Have to monitor the patients, monitor, record your vital signs. So just remember, no Geodon and Haldol to the same patient. Now, when you have the true excited delirium, or you think this is the excited delirium, you're called by the police, this guy is totally, totally uncontrollable, big, you can hardly get near him. The cops are thinking whether they're going to tase him and make him worse. And these people suddenly die often. Probably a cardiac and or stroke kind of issue. You give them both drugs almost simultaneously. And the dose, and then, because you're only going to get IM in them, give them 10 milligrams of Versed and 10 milligrams of Haldol, or 10 milligrams of Versed and 20 milligrams of Geodon. Geodon they really like Geodon because, first of all, it was available, and it's expensive, and we always like more expensive drugs. But it's a slower onset than you would think. So if I had my choice, I would give them the Versed first because it's working. And then give them 20 milligrams of Geodon. And, once again, don't give Geodon and Haldol to the same patient. It's one form or the other. Okay. Clear? Okay. Pain control. This is to give you an advantage for little kids. Well, a perfect example. A child falls out of a tree, breaks his forearm. You get it in a splint. He's still whining and painful, and his mom and dad are there, and they want, and they say, give him something for pain, give him something for pain, give him something for pain. But the child screams and hollers and fights you with your IV, and not every little kid who has a broken wrist needs to have an IO in their, you know. So we can give, this is a nice review. I like the name, it's clear as mud. Intranasally administered fentanyl has been studied as an alternative route for pain relief for children. All the studies showed similar or improved pain scores when compared with other opioids and administration methods. No severe adverse outcomes were reported. Current evidence suggests that it's safe and effective method of pain management for children in a variety of clinical settings. Another one, an intranasal dose of fentanyl at a dose of 2 micrograms per kilo provides effective analgesia for pediatric ED patients with painful orthopedic trauma within 10 minutes of administration. And we have the equipment, and it's easy to use. So you don't always have to start IVs on these little guys. Now, we know this is the general thing for fentanyl. Fentanyl is normally given in 25 to 50 microgram increments for adults, but in children, 1 to 2 micrograms per kilo may be given intranasally. If you think the child needs 2 mics, go ahead. If you think that, you know, if you want to try to do 2 mics and then see, or 1 mic per kilo and see how it works, fine too. You can give up to 3 mics per kilo total dose. And of course, for adults, we don't give more than 200 micrograms per hour as a usual rule. Rapid injection IV may cause respiratory arrest or chest rigidity, so you give it fairly slowly. IN, I don't think there's any worry about that. You just do an IN, you know, to do that atomize, you just squirt it. So why would you use pain control? Facilitate packaging and transport, patient exacerbation of symptoms. They do well if they start having more discomfort, or if just to relieve their discomfort. You can give Versed for adults, of course, for cardiac chest pain, abdominal pain due to aortic dissection, musculoskeletal pain, burns, chest wall pain causing splinting, etc. Side effects of fentanyl, and it would be intranasal as well, although the side effects have been studied and are very, very minimal intranasally. CNS depression, hypotension, hypertension, somnolence, allergy to it, respiratory depression, nausea, and with the caveat always to avoid use of narcotics for chronic pain syndromes for transport. You don't have to give somebody who say, oh yeah, I have my back pain that I take 100 milligrams of 10 milligrams of Dilaudid every 6 hours for at home. It's worth, and you know, I don't know what I did, but it's really bad. I need some fentanyl on the way in. No. No, you know, you say, you know, there must be some reason that you're not reacting to your pain medication. We don't want to confuse this. Bring them to the hospital. Let us sort it out. Now, people get nauseated with narcotics. I just want to make sure that everyone is clear that the dose for adults of Zofran is 8 milligrams IV single dose. We have in the past had 4 milligrams, and you can repeat, but there's no point in doing that. 8 milligrams for the adult, and then that's it. If it didn't work at 8, it's not going to work. Maybe you can give them Haldol. It's an anti. No, I take that back. You can give Versed for muscle spasms, 2 to 10 milligrams IV for muscle spasm associated with severe pain. Say a guy has done something that obviously appears to you, he's got muscle spasm, back pain, and muscle spasm. It's a good addition. Use the smaller amounts and move up. I changed the rule. You don't have to call medical control for that. Give them the 2 milligram, but give them in increments. Because remember, Versed potentiates the fentanyl. Be sure you have an adequate dose of fentanyl on board. Now, all patients should be monitored for respiratory depression. All patients getting fentanyl, getting narcotics should be monitored for respiratory depression, hypotension, cardiac rhythm, which is why you put them on a monitor. If they have a problem, treat it. Okay. Questions on nasal fentanyl and fentanyl in general? No. No, I'm not into it or into it. Okay, a couple of changes in our trauma protocols. Okay, we have a new change. Now, I don't expect that it's going to happen, that you're going to remember it right off the bat. We are taking out the terms trauma team and trauma alert. Oh, I know, but this is to become consistent with the statewide nomenclature system, and also to become consistent with communication in hospital. So we will now ask you to say full trauma activation, that is trauma team, or modified trauma activation, which is trauma alert. We are going to have that take place by November 1st. Okay, ish, yeah. Mark says November 1st-ish. So we will let you know the exact date. We'll keep reminding you. So, and full trauma team are the box 1 and box 2 of your trauma triage tool. So nothing has changed, just those words. It's like the ACLS test. We never change the questions, only the answers. Full trauma activation is box 1, physiologic criteria, which is Glasgow Coma Scale less than 14, systolic blood pressure less than 90, or respiratory rate less than 10 or greater than 29, less than 20 in an infant under a year. So that hasn't changed. That's been your rule all along. No difference here. Same with box 2, which is full trauma activity. This is the anatomic criteria. Penetrating injuries to the head, neck, torso, extremities, proximal to the elbow and knee. So any truncal and neck penetrating injury. Head injury, but your Glasgow Coma Scale has probably got you in there already. A flail chest. 2 or more proximal long bone fractures. 2 femurs. A femur, maybe in a humerus. There's a little fudge there. Crushed, degloved, or mangled extremity. That's going to need special treatment, special trauma treatment. Amputation proximal to wrist and ankle, pelvic fractures, open or depressed skull fracture, and paralysis. Okay, those are the trauma team already. Just now we say full trauma activation. If you want to say trauma activation full, that's fine. Now, modified or trauma alert. Falls, adults more, see, this is the mechanism of injury criteria now. Adult falling more than 20 feet, 2 stories. Now, if they're old, you fall from ground level, that could be significant. And that's down there on the list, too. Children more than 10 feet or 2 to 3 times the height of the child. High-risk auto crash with intrusion, and you know the numbers for that. Ejection, partial or complete from the automobile. Death in the same passenger compartment. Vehicle telemetry data consistent with high risk. Has anybody got any of that ever? I don't think they publish it, yeah. Auto versus pedestrian, auto versus bicyclist, motorcycle crash, greater than 20. And then the special considerations, these are the ones. So age, older adults, risk of injury or death increases after age 55. Older adults are the only category, the only age category in the state of Washington that's having an increased mortality from trauma since the institution of the trauma system. Everyone else is decreasing. Children, obviously, it's nice to triage in the pediatric capable trauma centers. The trauma center is pediatric capable, but we don't hospitalize if the child needs to be hospitalized. So there will be some times where you're transporting and you're giving your report, and they will suggest, why don't you take this child directly to, if it's stable at this point, take it directly to Randall. Anticoagulation and bleeding disorders. Somebody's on Coumadin, somebody's on Pradaxa. It's even worse if they're on Pradaxa than some of the newer ones, because we can't reverse those. So that's one of the reasons that older people falling down from ground level falls now are high risk, high mortality, because they bang their head, get a subdural, that's that. Burns. We know where burns go. And if the burn fits the anatomic, or if the burn has concurrent anatomic and or physiologic criteria, or if it's greater than X%, we're going to take them directly to the burn center. But a patient who has other injuries, let's say they're in a car wreck and then they're burned up too, patient who has those other injuries are going to take, you're going to die of the other injury before you die of the burn injury. So if your Glasgow Coma scale is 6 from your head injury in your car wreck, even though your car exploded and burned up, and they look kind of crispy, they're going to need to have that head injury taken care of before, at the same time, and you can't go to the burn center and expect the neurosurgeon to show up at the burn center. Doesn't happen. Burn center is separate. Time-sensitive extremity injuries. That'd be a pulseless extremity from a dislocation. That will get you into the trauma system all by itself. Pregnancy greater than 20 weeks, paramedic judgment. Craig Newgard paper that we published as part of the ROC study, the trauma ROC studies, showed that the reason that most paramedics take patients to a trauma center is paramedic judgment. It's by far the number one. It's the highest percentage. Wow, that was a bad accident. This guy really looked bad. Physiologic criteria is okay. His other stuff's okay. One thing on physiologic criteria, before I close this, I want you to understand that it's really important. your first blood pressure. So if you have a blood pressure less than 90, I want to know that. And that patient gets entered into the trauma system as a full trauma alert. Even if the next blood pressure you take is 100, because you've done some intervention at that point. You usually got a line going, you've got a number of things. The first blood pressure really correlates with bad things that are going to happen to that patient by the time they're at the hospital or later on in the hospital stay. It does correlate with that. Now, with our change of trauma things, we're also going to change trauma scene times a little bit. A couple of interesting articles here. Looking at trauma transport times, trauma scene times, and this is McCoy's paper, and the salient part is we observed increased odds of mortality among patients with penetrating trauma if scene time was greater than 20 minutes. Another one, this is another one from Craig Newgard at the Hill, part of the ROC studies. In this North American sample, there was no association between EMS intervals and mortality among injured patients with physiologic abnormalities in the field. We couldn't find anything which would identify scene time. Another one, same authors, golden hour. Among out-of-hospital trauma patients meeting physiologic criteria for shock and traumatic brain injury, there was no association between time, scene time, and outcome. However, the subgroup of shock patients requiring early critical resources and arriving after 60 minutes to the ED had higher mortality. Now, this doesn't give you a buy off on scene time all by itself. American College of Surgeons they picked that 10-minute scene time. They picked that the way they often pick things out of a place we don't want to talk about, and it's been stuck on in our memory bank forever. The point is, it probably makes, in town, in most of Clark County, we have fairly rapid scene to hospital. And in the outlying areas, you have fairly rapid scene to hospital if you call in life flight. We want to keep the total time well under an hour. Matter of fact, if you're in the half-hour business, that's good. So, but we're going to make a little bit of change in the time on scene, which will be in your orders now. Time on scene won't change. If you can't provide an airway within 2 minutes, then you should start transport. If the patient needs an airway, then transport the patient immediately, unless there are extenuating circumstances. Medical scene on time is still 30 minutes or less after initial encounter. STEMI and CVA will continue to be 15 minutes or less after initial encounter. Full trauma activation, 10 minutes on scene, once extrication has been accomplished. Modified trauma activation, 15 minutes or less. So with physiologic and anatomic criteria, get them out of there as quickly as possible. Now, sitting in on the Portland area committee that works on protocols, they don't think they have any scene times in Portland on traumas that are less than 10 minutes. They wanted to throw it out altogether, and the surgeons, trauma surgeons, said, no, you can't do that. It says that right here. So we're going to be evaluating that fairly closely, but we'll go for 10 minutes and 15 minutes for the trauma alert, well, what was trauma alerts, the modified. Code 99, I'll give you 30 minutes or less after initial encounter, because you usually work it at the scene. Now, we've been having really quick ROSC. So, and then, you know, you get ROSC, you boogie, you go. One last thing, I guess, on trauma, and we'll take a little break. Penetrating neck injury. This is Journal of Injury, and it's from military experience. Data suggests that it's very unlikely that penetrating ballistic trauma, it's a nice way of saying gunshot, to the neck will result in an unstable cervical spine in survivors. You may get shot in the neck and you may die from that, but you didn't die because of unstable cervical spine. And you don't have an unstable, most of the time you just get shot in the neck and it takes out vessels and nerves and things, but it doesn't make your neck unstable. And if you put a cervical collar on someone who's shot in the neck, it may hide potential life-threatening injury that you need to evaluate. You can't see what's going on in the neck. You can't see the expanding hematoma. You can't manage the airway. So remember, patients that are appropriate for full long board immobilization are blunt trauma with altered level of consciousness, spinal pain or tenderness, neurologic complaints, anatomic spinal deformity, high injury, mechanism injury with intoxication, inability to communicate, or distracting energies. So this is your spinal immobilization procedure, which has not changed for 25 years since we wrote the first thing. If yes to any of the below, immobilize. If no, may transport without spinal immobilization. Patient mentation. Is there a decreased level of consciousness, alcohol, drug ingestion, loss of consciousness? Subjective assessment. Do they have cervical, thoracic, lumbar, spine pain? Is there numbness, tingling, burning, weakness? Objective assessment. Cervical, thoracic, or lumbar deformity or tenderness, other severe distracting injury, which is always the argument. Is a burn severe and distracting? Well, if it's a second-degree burn, probably. Is a fractured clavicle a distracting injury for the neck? Absolutely. Is a fracture any place a distracting injury? Probably, but I could argue that if they have a fractured ankle and it hurts and no other findings, they probably can tell you accurately they don't have neck pain. So it does take a little judgment, which is why we pay you the big bucks. Is there pain with cervical range of motion? How do you test that? Well, if they say I don't have any, I feel them, they don't pain, and then they gently start to move their neck, ask them to move. I say, oh, that hurts. Well, then that's pain with movement. If there's penetrating neck injury without neurologic deficit, you can treat and transport without spinal immobilization. Now, the thing we've done to keep the trauma surgeons happy as much as anything, and they're all good, but all patients who meet trauma system activation criteria, full or modified, due to blunt trauma mechanisms, will have, at the minimum, a cervical collar on. If the patient's up walking around, if the patient were, even if the patient weren't walking around and for some reason you couldn't immobilize them flat on a board because it makes them not breathe well, put them in position of comfort on the gurney, secure them to the gurney, but with a C collar on. So If they're ambulatory at the scene, C-collar, immobilizing the gurney. Patient requiring long transport, C-collar, immobilize the gurney. Patient where a long backboard is not otherwise indicated and you're transporting the ED, just immobilize them to the gurney. Still, minimizing movement and spinal precautions is still paramount. All right, we need to take a break for a couple minutes, for about 10. Now you're going to have hospital emergency care. This actually came from a American Journal of Respiratory Critical Care Medicine. One of the researchers is, a couple of them are out of Seattle. So the EMS personnel care for a substantial increasing number of patients with severe sepsis and spend considerable time on scene and during transport. Given the emphasis on rapid diagnosis and intervention for sepsis, pre-hospital interval may represent an important opportunity for recognition and care of sepsis. Previous research has shown advanced notification of time-sensitive disease states, such as STEMIs, such as strokes, can improve outcomes and time to initiation of treatment. So, Clark County Protocol for shock, general considerations. Tachycardia may be the first sign of shock. Pulse pressure often narrows prior to fall in systolic blood pressure. Changing level of consciousness, an important cue. We see that, and clue. We see that a lot, particularly in elderly persons in nursing homes, where after a couple days they call you and say, you know, they're not their usual level of consciousness. So they haven't eaten anything for the last 2 days. You walk in, you smell the familiar odor of urine, and the patient's obtunded and is probably septic. Initial intervention for sepsis per protocol is airway, oxygen, vital signs frequently, EKG, Trendelenburg, if they're frankly in shock and not, if they can tolerate that without interfering with aspirations. IV large bore with balanced salt solutions. For hypovolemia, assumed from sepsis or neurogenic shock, 2 liters rapidly as possible or until systolic blood pressure is in the 90 to 110 range, neck vein distension occurs, or pulmonary valves develop. Pediatric fluid challenge for sepsis is 20 cc's per kilo, repeated up to twice. Now, this is from your general protocol for shock. If this is a head injury and shock, current studies are showing that you need to maintain a little bit more blood pressure. Usually for trauma, we like to target blood pressure somewhere in the 90 to 100, sort of a permissive hypotension. If they have head injury and shock, studies show that you need to have it a little, probably the sweet spot is 110. So target your blood pressure at 100 to 110. Maintain normal ventilation rate, remember head injury, normal ventilation rate, target your EtCO2 at 35, no less than. 35 to 40 is a good number. Now, if this is sepsis and or neurogenic shock, guy's been in a car wreck, has, you presume a complete spinal injury with neurogenic shock, not responding to fluids, or sepsis, not responding to fluids, dopamine. So 2 to 10 mics per kilo per minute. And it's the same dose for children, so 2 to 20, a little bit. They're a little bit more tolerant of that. Now, suspected abdominal aortic aneurysm, we'd like to keep your blood pressure in the same as the trauma range, 90 to 110. On the lower end, they're going to bleed more likely or chance of rupturing if you increase their pressure. Now, cardiogenic or DKA, etc. type of shock. Fluid challenge, 2 to 300 cc's over 5 to 10 minutes, repeating as needed unless they're developing RALs. I would kind of prefer an epinephrine drip if you have cardiogenic shock. You could use a dopamine drip or an epinephrine drip. Rapid transport. Now, for septic shock, now these are the cues that we try to think of sepsis and septic shock. Known or suspected infection. So these are the definition of a of SIRS. Known or suspected infection with 2 or more of the following: either hyperthermic, temperature greater than 38, which is 100.4, or less than 36, which is 96.8. A lot of these older persons in the urosepsis from the nursing home will end up being actually hypothermic. Respiratory rate greater than 20 per minute. Heart rate greater than 90 per minute. And EtCO2 less than 25. Obviously, they're breathing rapidly. They're getting rid of CO2. So if you have suspected infection, suspected sepsis with any of those, any 2 of those, notify the facility, septic shock alert or sepsis alert, however you want to characterize that. Okay. Clear? Okay. Stroke and CVA. Now, we're not going to go into the full stroke scale. This is an interesting article, which is actually, at this time, almost 10 years old, but people are now starting to pay attention to it. It's a simple 3-item stroke scale. I'm going to make it even simpler so you don't have to make a stroke scale. But basically, it looked at the prediction of usually the worst kind of strokes and the ones that can be dealt with by intervention. And intervention has now been shown with 6 studies that intervention, neurosurgical and or neurointerventional radiological intervention, removing the clot with a number of clot extracting devices, has been shown to significantly improve outcome from severe stroke of the middle cerebral artery. And the things that predict middle cerebral artery occlusion, the finding of stroke, are profound aphasia, significant paralysis to the point that they are unable to raise an extremity off the bed, right arm, right leg, or both, and comatose. So, with those 3 findings, if you had a choice of hospitals to go to, with any of those 3 findings, you would make the choice that a person should go to where we could get neurointervention done, because those are the likely ones that are going to need neurointervention. So we're changing the protocol just a wee bit. So your protocol for stroke and CVA is primary survey, fast assessment, determine onset of symptoms, last time known, normal. Protect and maintain airway, patient in the lateral position on the paralyzed side. If they're paralyzed, if they're not paralyzed, you don't need to put them on the lateral position. Airway control as needed, suction as needed, high flow oxygen. If you suspect intracranial bleed, maintain normal ventilation rates, target ETCO2 at, it says 30, it should be 35. RSI is needed. Titrate oxygen to the lowest level required to achieve SpO2 of 94 to 99. You don't want to go over 99. Don't want to go to 100%. In fact, so you should really target it about 95, 96. Too much oxygen is bad for injured brain, too. Maintain ETCO2. Oh, there it says now. Got two different things, right? ETCO2 at 35 to 40. This one has to be changed. We'll go back and get that. If the patient is conscious, reassure them. Patient may understand everything, even though they appear confused or comatose, they may understand. They're just not able, they're not able to speak, to articulate that. Consider other causes of abnormal mental status, means hypoglycemia, drugs. Consider and evaluate for predisposing conditions for stroke, hypertension, dysrhythmias, particularly atrial fibrillation. Altered mental status protocol, glucoscan, D10 if they're hypoglycemic, Narcan, thiamine as needed by your judgment. If they're hypertensive, assume a bleed, don't attempt to lower pressure in the field. Transport emergently, code 3, if there's less than 8 hours onset of the following symptoms: aphasia, facial droop, unilateral weakness or paresthesia, inability to understand or verbalize, loss of vision in one eye or visual field, vertigo, sudden onset, persistent, progressive with headache. Or went to bed normal and woke with symptoms, although we don't know, we didn't used to know, we didn't used to transport that emergency. We now do that. That goes to the intervention hospital, because a lot of those patients we will take to intervention. And a lot of people wake up because of their onset of symptoms, turns out. Notify facility of a code 3 stroke. The emergency physician now will, at least at Southwest, will see the patient quickly in the room on your gurney, make the choice. This is a neuro 911, and it will go directly to the CT scan on your gurney. You will push them down there, put them on, and then you're gone. If he says this is not a neuro 911, the patient goes onto the bed in the room, and you're out of there. Now, patients meeting stroke and CVA criteria will be transported as per this. Symptoms 2 hours or less can go to the closest stroke center or to patient family choice. However, patients older than 80 will go to Peace Health Southwest, because they cannot get routine TPA. Symptoms more than 2 hours should go to Peace Health, because those patients will likely not get, will likely go, more likely go to intervention. Suspected intracranial hemorrhage of any duration goes to Peace Health. That's where the neurosurgeon lives. If the patient exhibits, and this is the change, if the patient exhibits signs of profound paralysis, can't raise their arm, can't raise the leg, aphasia, or is comatose, transport those to Peace Health. Dr. Mock said to me several months ago, why don't we take all patients to Peace Health? And that would be the simple answer, but we live in a world of politics, don't we? It may come to that because Legacy is working on developing these on managing these criteria of profound paralysis too. So now the receiving stroke team, remember, they require more medical history from the patient's caregiver. It would be nice if the caregiver is there at the time. If they can be transported with, so much the better, but they need to arrive as quickly as possible. If not, get a phone number that works, that we can, that the hospital can talk to the family member or caregiver. Any particular heartburn about that? Now, here's a couple of changes in ALS assist protocols. Now, properly trained EMTs are allowed to assist paramedics with the performance of the following procedures while on scene. Now, and properly trained means we do have protocols, we do have training set up to train them in these things, and they have to have gone through these before they can say, yeah, I can do these. That's not your individual responsibility, that's the agency and department's responsibility. They can place 12-lead EKG monitoring electrodes. They may also, if they're in the more, and there are some more rural areas where perhaps District 10 would get there before, well, actually it would be more, in parts of District 3, EMTs will get there before, they're not 100% ALS yet, so District 3 may get there several minutes ahead of an ALS ambulance or the other ALS crew, depending on where that is. Same thing for Clark County Fire and Rescue. If the EMT may run that 12 lead to a place, so I'd like to see it. I'd like to see a 12 lead on anybody complaining of non-traumatic chest pain. You know, I don't care if they're 12 years old. If they're having chest pain that makes you think, well, this could be cardiac, I suppose, but they're too young. No, get a 12 lead. What does it hurt? And you never have to say you're sorry, and you don't have to say you're sorry in my office. Get it. If you got chest pain, get it. If you think cardiac. So I want the EMTs to think that they can put the 12 lead on and run it if you're going to be 10 minutes away. And they can call you and say, hey, you know, I think I got a STEMI. Or when you walk in the door, here it is. It's already in the protocol. No, it's in the state protocol. It's been in the state protocol for 15 years. No. So, paramedics can, or EMTs can, at your instruction, after they've been told, after they've been instructed how to do it, you can say, hey, start this IV, spike the bag. They can determine blood glucose determination via finger stick. North Country EMS and Fire District 13 and 10 have King Airways. And an EMT can place a King Airway. In the rest of the county, EMTs are currently placing iGels. We're training most in our protocol to do the high intensity CPR and the pit crew CPR. The EMTs have been trained to place the iGel. We're working on training a bunch of trained monkeys to place the iGel. It works probably too. iGel is a great device that works easily. Doesn't interrupt and the medic can stay busy. They can give intranasal Narcan if we've been trained at your instruction. They're not carrying it themselves, but they can use it. Put the if they've been trained to the intranasal Narcan, my God, we're training patients at home to give, persons to give Narcan to their, quote, loved one who goes down with it. As a matter of fact, here's the thing. IN naloxone. I'd rather have the EMT use intranasal Narcan because it avoids a sharp. There's too many sharps lying around. But for the home kits, there's a Narcan auto-injector, which you can get, which now your friends and neighbors can have, knowing you're the happy junkie and sometimes aren't a very good chemist, and go down and they can use the Narcan auto-injector, which I haven't seen the price on it yet, but I imagine it's somewhere around $400. Now, there is limited immunity for, right now in our law, for people who seek medical assistance in a drug overdose. So if they call you and say, I think my friend, we encourage them to call and say, I think he overdosed, because they can't be prosecuted, and nor can the person who overdosed. So the only time I want EMTs to use Narcan, and we have in District 3 now and in Clark County Fire and Rescue trained EMTs to use IN Narcan if the paramedic's not there, because they get there before the paramedic, and there's no reason to have someone go 5 to 10 minutes who is depressed respirations, apnea, and or hypotension. So we treat altered level of consciousness, unresponsiveness with depressed respirations only and hypotension only. So they have to have major symptoms of an overdose. They may or not have pinpoint pupils depending on the drug. If there's simple intoxication with narcotics, if they're just loaded and they don't have respiratory depression, they don't need to be treated by the EMT. I don't want my Narcan used for that. It's expensive for us as well, plus it's unnecessary. You don't want to wake them up and become a raging withdrawal case. Paramedic will titrate that as needed. Okay, a couple of other things. We changed newborn resuscitation to fit the American Academy of Pediatrics Neonatal Resuscitation Program and the American Heart Association, which says basically, unless a baby, even if a baby has meconium staining, unless they're having respiratory distress, you don't really need to do much about it. That's the bottom line. So our protocol has changed to only read, if thick meconium or secretions are present and signs of respiratory depression, depressed muscle tone, and or heart rate less than 100, then you can intubate and suction the trachea. Otherwise, even with meconium staining, most kids, they can have meconium staining, and if they're breathing normally and acting normally, no big deal. I already mentioned this one. Pain control with painful muscle spasms. You don't have to call medical control for concurrence now. You can give it on my orders. It'd be nice to titrate the Versed up to, don't bring them in totally stoned. Okay? Status asthmaticus for adults, even, I have added epinephrine 2 to 10 mics per minute drip. I'm back to the good old days. We do it already for pediatrics. For status asthmaticus, I'd rather not have people die of status. Now, status means that they're not responding to your regular treatment. You're already doing all the things you're doing, plus you've probably given them magnesium, and you've got them on a continuous med-ned, and you give them Solu-Medrol, and you give them everything else. Put them on a drip and see how that works. Now, you've got them on a monitor anyway. Seizures, measure motor. Versed, 2.5 to 10 milligrams, IV or IM until the seizure stops. Child, 0.1 to 0.2 milligram per kilo IV or IM, slow IV push, may repeat times 1. So it means you can repeat the Versed. Newborn volume resuscitation, I think we had an error in thing. We corrected it. That's newborn volume resuscitation is 10 cc's per kilo, not 20 for pediatric. So we made that correction. Now we're having a continuing conversation and confusion and issues with legal blood draw. House Bill 1276, which I think went in 2 years ago. I think it's a year and a half ago anyway. And then was amended again this year. It's legislative amendment to rules pertaining to impaired driving because they had to stick marijuana and other drugs in there. You know, so this is to increase the availability of forensic phlebotomists so that offenders can be appropriately and efficiently identified. That's a nice way of saying we need ways to catch people who are drunk and stoned because they don't have a breathalyzer for marijuana. So you can only do it by a blood draw. They made it so it was not professional misconduct. You cannot be sued. It's not a problem for an advanced EMT or paramedic licensed. Well, they forget you're not licensed. You're certified, but this is the same thing in the state of Washington. To collect a blood sample without a person's consent. So you can collect a blood sample without the patient, without the person consenting to it, if withdrawing blood was directed by a law enforcement officer for the purpose of a blood test under the provisions of a search warrant or exigent circumstances. And the exigent circumstances are no different than they used to be, and I'll get to that in a minute. However, they added that a person could do a voluntary consent at the request of police at the scene. So we've made a little change. Now, this is their special thing, and I can't read that any more than you can because we had to. This is what the state police have. And these are the special things where they can ask you, and it's no different than it used to be. They could ask you to draw blood. If the patient was unconscious and there was an accident involving severe injury or death, if the patient's unconscious or if they're under arrest for vehicular homicide, and they have it in Spanish, so you can read that too. If they're unconscious and you believe that they were driving and the policeman believes they were driving under the influence. Of course, if they're unconscious, they're already a patient. So you already have presumed consent to start an IV, and you have presumed, and then you can draw blood. Okay? They're going to be a patient. If they're a patient, there's never any problem with you drawing the blood. If this is a felony DUI, and that is a special thing now, a felony DUI means that someone is, there's been a severe accident or maybe they're stolen a car while they're drunk, or there's a felony besides the DUI. Or, I like this one, felony physical control. But they have, this is all done for the state police, and I'm presuming that the locals will do it too, with little check boxes. Or this is a vehicular assault. That's no change. We always had that. Or so they're under arrest. Or this is a DUI arrest resulting from an accident with serious bodily injury to another person. So they can ask you to draw blood in any of those cases, but remember, they all said they were under arrest, essentially. Or you can, they'll tell you, we're going to draw your blood whether you want to or not. Do you want to consent to that? At the scene, if they consent, say yes, then you do a blood draw. The police have to have the equipment for you. You're not carrying it yourself. You draw it, and you draw it under the rules, which are, you don't use alcohol to clean off the site. You use betadine or, yes, spit. You take some of the patient's own, that they take their rye whiskey out of the back, splash it on them. And then this is the voluntary blood draw consent. And so you can draw it at that point and give it to, and even if the person is not a patient, but as long as they're under arrest and they're voluntarily consenting. Now, we're working with the local police who would like, if they don't voluntarily consent, if they don't voluntarily consent, it tells you that all sorts of bad things will happen to you. Like you'll lose your license, your children will have to work for nothing for years. It goes on and on and on. So I'm not really sure what part of voluntary I understand in this, but if they don't volunteer, the tendency is that they're going to take them to jail and get a judge's warrant for a search warrant, which is basically says, you will give us blood. You don't have a choice. Now the question is going to be how that's going to be done and whose responsibility that is, and I'm working that out with the sheriffs and the police, because in many cases, some of the local agencies said, yeah, we'd send the medic there to the jail to draw blood rather than have to take the person all the way up to, let's say, Longview. We'll draw the blood at jail if there's a warrant, but we can't do it. We have to do it aside of our 911 activity. So if somebody, if you're going to the jail and you have an emergency come up, you end up going to the emergency first. So we'll have to work that out. Okay. So we will give you clear instructions, but we will provide that stuff for you that you can, if you have a legal, if they give you a legal request, you can draw blood and you have immunity from the patient cannot, the person cannot say, hey, they drew blood on me, they assaulted me. No, that doesn't work. You are protected. But I want to be very careful and not have to, have you, where are we today, Mark? Yeah. Woo. I got it. Okay, a couple of case reviews. Priority 5 on unconscious. That was what we dispatched it. On arrival, found patient in mother's arms standing in living room. Yes, folks, this is an ALTE we're going to talk about. Patient is a 3-month-old male. Patient weighs 13 kilos. Chief complaint, patient slow to arouse from sleep. No recent illness, no recent behavioral abnormalities. Mother relates she put her son down for a nap, and when she went to check on him, he didn't respond. She picked him up again, and again he didn't respond. She relayed this lasted about a minute before he began to respond to her and then acted totally normal. So that's an ALTE, an event that scares the person. On our arrival, patient seems alert and responds to our evaluation by crying or sucking his thumb. Mother relates patient never stopped breathing but may have been a little bit more pale than normal. Color change when she first picked him up but didn't say with any certainty. Mother also denies fever, any recent medical problems, relates the only medication the patient has ever received has been occasional periodic Tylenol, doesn't remember when the last time was the child got Tylenol, but wasn't recent. Temp 97.6, pulse 136, respirations 28, skin's warm, dry, and pink. Lungs are clear, abdomen supple, good muscle tone. When asked if the patient had been unattended or left in anyone else's care recently, patient stated they've all been home all day. Patient's always been with them. Advise family that we should transport via ambulance for evaluation of ED, but mom and grandma insist on taking patient to their pediatrician. Recommend that we call pediatrician directly. This is before we had the protocol. Recommend call pediatrician directly while on scene to ensure that they do or don't want the patient taken to an ED instead of their office. Patient denies that, insists they would just transport patient to the ED themselves. Patient mother signs refusal of transport form. Well, this kid never got to the ED, never went to the ED that day. He had been in the ED 8 days old with a brief episode of wheezing when supine. Thought the only thing they noted was that the parents did smoke. The family had reactive airway disease in the family. They probably gave them grief because they smoked and probably didn't want to go back to EDs again. But he was sent home from that at 8 days, and ED care was perfect up to the point, and we've now added to the protocol that medical control concurrence for leaving a patient. We don't know what happened to this kid since. I don't think anything has happened as far as we know, but this is the kind of case that that may turn out to be a problem in the future. It'd be interesting to see if it pops up again. We know where this kid lives, so we can keep an eye on that. But that's a simple ALTE. I think the outcome is probably okay, but should have had medical control concurrence to leave at home. Case 2. It's an adult. Dispatch on a cardiac respiratory arrest. Patient's friends were present and related. Patient was standing in his living room when he suddenly collapsed. Friends say the patient was not breathing, had no pulse that they could find. He had they didn't think that the patient had any complaint of chest pain or a difficulty. He's been under a great deal of stress. It's a past history of atrial fib, aortic stenosis, diabetes, angina, hypertension, hypothyroidism, and a triple bypass 10 years ago. 69-year-old male on arrival, laying supine on the floor with patient's friends attempting to perform CPR. Was he getting telephone instructions too? I think. Patient was pulseless and apneic, airway clear, head and neck purple. Arrested patient's skin was pale, warm, and diaphoretic. Pupils were fixed, trachea was midline, abdomen was soft, patient's neck and back intact, extremities intact. Primary assessment was done, CPR was taken over from bystanders, cardiac monitor turned on, and defibrillation pads attached. OPA placed, ventilate patient with BVM, IO established, rhythm check, VFib, defibrillate patient, continue CPR for 2 minutes, epi given in that time period. Rhythm check, patient had ROSC with palpable radial pulse. 12 lead obtained, ST elevation to multiple leads. Package patient for transport. While packaging patient, cardiac rhythm returned to VFib. Defibrillated number 2, started CPR for 2 minutes, gave ALPS 1A and 1B, hurrah, hurrah. And that was the next 12 lead. Rhythm check, patient had ROSC with palpable radial pulses. Initiated transport, IV started. IV was now started in the left antecubital, given 400 cc's of normal saline total, began breathing on his own, had gag reflex, OPA was removed, ETCO2 placed, cannula placed on patient, reassessed patient during, he gradually better. Upon arrival, medical center patient was speaking while being transferred. This is actually Marty Bell's summary of the case. And did you take care of this patient?
Yes.
Yeah, it's even better.
Both of the arrests I did.
Ah, you're the cardiac doc. So he had known severe ischemic cardiomyopathy, but he did not have an ICD originally. Argument might be that he's kind of the patient who probably should have had a implanted defibrillator. At any rate, so he was defibrillated. He got his ALPS drugs, 1 and 2, A and B, and initially obtunded him more and more alert. He was confused, wheezy, improved with bronchodilators and brief BiPAP.
It was just a brief time that he was on BiPAP that really improved his mental status, his respiratory status, and stable.
Now, he had his second 12, initial EKG.
He was hypovolemic, though. It was, I can't remember exactly
Right.
what it was, but it was low,
And that's, it had to be really low to get intravenous potassium. So put on an amiodarone drip. The cardiologist did not take him right to the cath lab, even though he had a 1 millimeter ST elevation in 3 and F, for a couple of reasons. Because he had severe aortic stenosis, he also had cardiomyopathy. He did, his troponin peaked out at a 22, so he had some myocardial damage. He was stable on the drip. His INR and kidney function were elevated, so he wasn't taken right to the cath lab. He needs to get his echo showed him severe, he had severe ejection, he had an ejection fraction of 20%, which is really low. So he needs to have a implantable cardiac defibrillator to keep him from having another episode. But this was really good job and really following all the resuscitation plan by fire crew and AMR crew, and then getting the patient rapidly in for other stabilization. But they did a great job. So we will probably have a little trouble following up with the Kaiser stuff, because he was a Kaiser patient. But hopefully he's had an ICD implanted.
Yeah, maybe it was a follow-up.
Yeah. Right. Here's a response. It was sent out code 3 for a possible cardiac arrest on a 7-year-old. On arrival, find the patient in a grand mal seizure. So, patient had been incontinent, no past history, no recent illness or trauma, never had a seizure, acting normal in the morning. Her AV-POO was unresponsive on all. She was given midazolam, 25 milligram IM. Seizure did decrease but didn't terminate. Vascular access was gained, blood glucose was normal, vital signs, her GCS was still 3. She got another 2.5 of midazolam, and now it says seizure terminated. Although they do note down here that her eyes were somewhere I found eyes were deviated. at any rate, she remained stable. She still had she ended up with a Glasgow Coma scale of 6, improving slowly, and now reacts to pain. Ultimately had complete termination of the seizure, transported code 3. She was given more sedation, initially flaccid on the left side with discontinent gaze to the right. Basic rule is you look toward a lesion and look away from the seizure focus. But I would argue that if she has discontinent gaze to the right, that may still be a seizure, or at least extremely postictal. Now, did you take care of this one? No. Okay. So she was given, so the hospital report, she's afebrile, non-toxic appearing. She continued to improve in the department with no seizure recurrence. Labs and imaging, including CT head, were all normal. Patient was discharged to follow with the PCP for outpatient MRI and the EEG. Since all the ED data was unremarkable, postictal confusion had totally cleared by time of discharge. So this is a first onset, new onset grand mal seizure, probably heralds underlying seizure disorder, but needs to have the pediatric neurologist work that out. So good stabilization, good evaluation by the crew. I appreciate giving her repeated doses of Versed rather than one big one, and making her, totally gorked out or respiratory depression. She was checked to be sure she wasn't hypoglycemic. All the things went well. Now, this is the motor vehicle. 2 patients, or multiple patients, 2-car motor vehicle. The patient we're concerned about is a 26-year-old male, unrestrained passenger of a 4-door sedan traveling at high rate of speed, rear-ended an SUV, and then came to stop against a fence. Unconscious, unresponsive upon arrival and for the duration of the call. Lying supine in the back of the vehicle with snoring respirations. Airway is adequately patent, however, there's bloody secretions. Top palate of mouth is totally deformed with a possible Lefort-type fracture. Breathing shallow, snoring with occasional grunts. Lung sounds present in all fields. Right pupil dilated compared to the left. Starring on windshield where patient sitting. No airbag deployment. Passenger seat broken and mangled. Laceration to left shin with no active bleeding. Spinal precautions are done. Suction blood in airway with the Ankauer type of suction. Got oxygen. GCS is 3. Lung sounds clear. Vascular access was done. Vitals, blood pressure 96/70, pulse 100, pulse regular. Now, they didn't, because they were able to adequately maintain oxygen saturation. I don't see I don't see a CO2 noted, and because of the airway, the upper airway, the mouth deformities, the palate deformity, they elected to transport, maintaining ventilations and maintaining just a BVM type of thing rather than to intubate or attempt intubation with this. This was a morbidly obese male. who was intubated orally in the ED with a trauma surgeon standing by to do a crike if that was necessary. This was done with the glide scope and was done, the notes were that this was taken with some with precaution of having it doubly set up to do a crike, but that's probably, you know, it was able to be done with the glide scope under good ED conditions, light, etc., and that probably was a good choice not to mess around in the field. He was taken to the CT where he had maxilla and nasal fractures, so his face was kind of done in, a small intraparenchymal right frontal lobe, and subtle poor gray-white differentiation, which means closed head injury. No skull fracture. C-spine's intact, TL spine was okay, but he had one L-spine transverse process fracture. Went to the OR for operative reduction of and internal fixation of the facial fractures. He had lip and eyelid lacerations as well that were done in surgery. He recovered in ICU, discharged home about 7 or 8 days later with cognitive defects. So he's got closed head injuries, not as sharp as he used to be. Family wanted to provide rehab rather than admit to post-hospital rehab unit. So patient is going to be followed by trauma clinic. I haven't seen the results of that since, but because of, you know, it was a good choice. Potentially difficult due to facial fractures and bleeding. So intubation might have been difficult, and the surgical crike is, you know, was considered. Now this last case, which is sort of how we go down the garden path of assumptions. Patient 1 on, quote, unconscious fainting. On arrival on scene, find patient care of CCFNR, CCFD3. CPR is in progress. That's fairly impressive fainting. It was initiated prior to EMS arrival. Here's what the bystander said. They called 911. They're down the way, down the road from the patient. They see the patient riding a bicycle, and he falls off the bicycle. They rush up to him, or however long it took to get there, and they found him to be unconscious, unresponsive, and no pulse. So they began CPR. Fire arrives, they take over compression, place patient on monitor in AED mode, and it said, don't shock. Monitor is then moved to the manual mode, and the medic on scene shocked for what he said was ventricular fibrillation. Looking at the chart after the, or the strip after the fact, this was probably simple asystole. So, they continued, so they did one shock. Whether it was appropriate or not, it's another question. EKG, so then they did another look, and they determined this was PEA on the second, after the first shock, after 2 minutes of CPR. Blood glucose is okay, IVs are started, capnography, patient's capnography shows CO2 value of 27. Medication is given epinephrine, altogether 5 doses of epinephrine given, because as we go along, the patient is intubated, CO2 confirms intubated. Oh, excuse me. No, did not make it, did not. First one is a miss. and they noticed food coming out of the tube. That seems to be an obvious not intubated patient then. So that was pulled, and they ultimately did another one. This time, they've got digital, they've got an ETCO2 confirmation. Naloxone is given. Sinus tachycardia, they have an ROSC. They move the patient to the ambulance. Patient loses pulses, unable to get some more epinephrine, continues CPR, loses pulses again, gets more epinephrine, on and on and on. Keeps going. Altogether, 5 or 6 of epinephrine, gets to the hospital with CO2 of 55. Oh, no, it's not even to the hospital yet. CO2 is 55. It keeps going up. More epinephrine, CO2 value now 26. CPR goes on. GCS, of course, is 3. Pulse 31. So, what do you think about this case, just out of curiosity? I mean, have we made appropriate assumptions? The guy was riding along, they see him fall off, and they find him in cardiac arrest, that this is they're assuming he had a cardiac arrest and fell off the bicycle. Okay. So, on arrival, they also found this guy to be massively obese, massively swollen abdomen on arrival. Don't like that. Placed an E-wall lavage tube to decompress the stomach. Copious food and semi-solid food in the stomach. He was sent to CT for a trauma scan due to the mechanism. Because what if this guy fell off his bike and then had trauma? And it wasn't that he didn't have a cardiac arrest and fall off. Trauma scan was significant for frontal parenchymal bleed and a subdural bleed, so he had head injury bleed. His C-spine was he had multiple rib fractures on the right side in both the anterior and lateral posterior rib cage with a hemopneumothorax, unstable right chest wall, moderate amount of blood in, but no significant tension pneumothorax. Patient was still unstable, arrested again. They ultimately called the case. I think Marty took care of this case too. In retrospect, traumatic injuries were the likely cause of ultimate instability and arrest. The ME, he went to post. The ME found no signs of acute PE or MI. Did comment on the above trauma findings as well as a liver laceration probably due to a broken rib. Now, we're not faulting anybody. We're just saying we're going to have to consider trauma at the same time as cardiac arrest. Not that it would necessarily change your approach, except that blunt trauma arrests from blunt trauma are typically lethal. When you go to a blunt trauma scene and you find a patient in a car wreck, blunt trauma, patient's in arrest, you basically can call it. That patient's dead. So, it's actually pretty heroic events, but the ED, not that, I'm not sure EMS could have done anything differently or should have done anything differently at the time. It's just that this guy probably wasn't dead when he fell off the bike. He was probably dead because he fell off the bike. Older, obese people falling off bike seem to have chest injuries. Older people falling off bikes have chest injuries, as I know. Any rate,
He was not that old, let's say.
well, it's 62.
62.
Yeah, well, that's,
But he was not in good shape.
yeah.
His abdomen was impressive. It looked, looked like he was pregnant basically with a full-term pregnancy when he came in, breathing very well.
Yeah, remember the PC, and that's a really good,
Yeah.
that's a really good thing about,
The airway was not easy. I had a,
No.
had a limited view even with the glide scope, so it was a very challenging. I can understand why it'd be very difficult for people. So the decision to go to a super glide
yeah,
Yeah, and the stealth trauma is a good thing to think about in your differential when you're in the PEA scenario, and you can't think of anything else that would be appreciated.
well, the other take home is, even though it wouldn't have probably decompressed him with that, is that arrests that are not going well, or continued hypotension, continued difficulty to ventilate people, you have to consider things like tension pneumothorax or gastric distension. And often with, when we have people in, when you intubate somebody and you can then slide an oral gastric tube down, that might have, now in this case, they had to put in an Ewald tube, which is, garden hose size, to get stuff out.
Apparently they eat recently.
Yeah. And frequently, and frequently. And then went for a bike ride to work it out.
Was he a DUI bike rider, or was he trying to get fit bike rider?
Yeah, great.
As a business owner,
So,
but yeah, even after we put in a test tube for depressants, I mean, there were
okay.
part of it.
Here's a couple quickies again, just to remind you that we have the SUDS program going on. That's mostly for the AMR people to think about. Fire can certainly remind them, but SUDS, sudden unexpected death syndrome. Any patient with a pre-hospital cardiac arrest, even and especially if you get an ROSC from, just get a blood sample from. The only thing we don't use in this, of course, just like everything else, traumatic, violent deaths, overdose. So draw a blood sample as quickly as possible. The kits are in the AMR crews, and label the tube, patient's name, EMS number, date of service. If you got a hospital face sheet, fine, good. Put everything in the baggie, put it in the ambulance cooler, move it to the refrigerator, and the soup takes care of it. Now, ALPS, we are still in ALPS. Non-traumatic out-of-hospital cardiac arrests, vascular access, IV or IO, persistent, recurrent VFib, VTAC after one or more shocks without open label amiodarone. What counts as a shock? Any shock except for ICD shocks. Any AED device, any agency device, any ALS or BLS administered shock counts as the first shock. Study drugs have to be given as soon as possible. You guys are doing a great job. Haven't seen one missed. Actually, we've had a couple of Kongs, kit opened and not given because they've come out of the box and the patient had ROSC. And they had ROSC before you could get the drug in them. So, but that's the way it's supposed to be. That one we like. We don't like it after you've given 5 shocks and then you say, oh God, I should have given the medication, the ALPS drugs. VFib, pulses VTAC is treated the same way no matter when it occurs. So if you get there, you give a shock or two and the patient has ROSC, and then on the way in on the ambulance, they go back to VFib. That buys you a quick dose of ALPS drugs 1 and 2, along with another defibrillation. So the doses, the first 2 syringes are ALPS dose 1A and 1B. That's the first dose. The second dose, if they continue in VFib and require more shocks is syringe number 2. Got to use that silly ClearLink adapter. I know you're going to miss that when it's gone. You put it on the tubing before you attach the syringe. That's how it works best. After enrollment, call the number. It's on the box. Call the number and tell them you enrolled the patient. Let the receiving hospital know that this was an ALPS patient. Now, in that first case we talked about today, they had ALPS 1 and 2, but they started the patient on the dose of, even though they know the patient got ALPS drug, they don't know whether they got amiodarone 1 or 2. They don't know whether they got amiodarone in that or lidocaine or normal saline, but it was no problem for them because they could start an amiodarone drip without any issues. Now, ALPS is almost to a close. We're beginning to put things together, and we're doing very well in our area. Clark County is still the furthest ahead. We still have the most ALPS cases. And it's anticipated, we're anticipating that we'll have enough cases in and they will stop the study by the 1st of November. Now, don't worry about that because we'll let you know when they stop the study, we'll notify the agencies that all of the ALPS drugs will be returned to ROC. At that time, we will go back to our original orders, which is instead of using, when you need to use an antidysrhythmic drug, you will then have amiodarone available. That's the drug we'll use until we get the results of the study. The study is, I don't think we'll actually get a final answer until probably March of next year, if I know how these things work. Probably somebody at Rock Central will have the answer by Christmas, but if they tell us, they'll have to kill us because you can't let this stuff out. The rules of this game is silly. Even if you know it works or something works the right way, you can't let it out until it's published for everybody. So we will go back to amiodarone like we used to have. But we'll let you know that, and we'll make sure that the agencies have the drug to put on into your kit. But the ROC things will just disappear when we say it's going to disappear. Any questions? You guys are doing a great, I mean, really, we haven't had a miss that I can think of over the last several months where the patient, where you didn't anticipate that the ROC med should be given, that the ALPS drug should be given. And then the patients have been just not cooperative. They're having RSC before we can give it to them. So that's okay. All right. Next month because we haven't figured out entirely next month, have we? Okay. All right. Thank you. Yeah.